Barb Johnston will be presenting today. Mo Keller, who is on the call but has one of her colleagues presenting from Colorado. Barb is from New Jersey. Shell Gross from Wisconsin, and Ben Harrington from Tennessee. And they help us coordinate all across the country, putting together our state and the most important policy issues. What they wouldn't be able to do, the wonderful work that they do, or bring you webinars like this or our 4 in-person meetings a year without our sponsors. So I'd like to take a minute to thank the Regional Policy Council sponsors for 2018. And that's Janssen, which is a Johnson & Johnson company, Allergan, Alkermes, Synovian, Neurocrine, Otska, and the Takeda-Lundbeck Alliance. Next slide, please, Karen. Mental Health America is the nation's oldest advocacy organization. We were founded in 1909. Next year will be a big birthday for us. And we are the nation's leading community-based nonprofit dedicated to addressing the needs of those living with mental health conditions and promoting the overall mental health of all Americans. Our work is driven by our commitment to promote mental health as a critical part of overall wellness. And our philosophy can be summed up in 4 simple buckets, and that is prevention services for all, early identification and intervention for those who are at risk, integrated care and services, and supports for those who need them, with recovery as a goal. And of course, all of that must happen, as we like to say at Mental Health America, before stage 4. Before we get into Tim's presentation, let me just take a minute to introduce our very good friend, Tim Clement. Tim is the Northeast Regional Field Director for State Government Affairs with the Department of Government Relations at the American Psychiatric Association. Tim is an expert in both the Federal Mental Health Parity and Addiction Equity Act, which is a mouthful called MAPIA, and similar state laws in all 50 states and the District of Columbia. Tim has written multiple pieces of parity implementation legislation that have been signed into law in several states just in this past year alone. Tim, along with several other parity experts, created a parity compliance tool for regulators that is currently in use in several states. Tim also led the creation of the Parity Track website at www.paritytrack.org back in 2015. And I'm going to turn things over to Tim right now. Tim?
Thanks, Debbie. It's a pleasure to be on the call with you guys, and I know that I've been on quite a number of RPC meetings and calls in the past. So as Debbie said, I think there's a lot of background. If someone could, okay, if someone's not on mute, it probably should be on mute.
Yeah, someone has. Well, Karen, can you mute that?
Hey, can you guys still hear me?
Yep, we got you, Tim.
Okay, great. Thank goodness we have 21st century technological solutions.
Excellent. Karen, we need Tim's slide, please, up.
But I don't know how to hook the audio. Okay.
There we go.
So again, as Debbie introduced me, I've been working on parity. That was implementation of the Federal Parity Law and related state laws was my only job for 2 full years. That was all I worked on. I lived in the weeds, both federal law and state laws. As Debbie mentioned, with the Parity Track project, I did a lot of work in terms of tracking legislation, regulatory actions as they relate to parity. And even after those 2 years I spent working only on this issue, I've probably spent 90% of my time since then still working on this issue. And this is the top issue right now for the American Psychiatric Association. We're so excited to work with Mental Health America. As Debbie mentioned, you guys are the leading organization for individuals affected by and living with mental illness. So we're so happy to partner with you guys in some of the state work. and we're really excited. I know that Debbie and some of your various chapters and affiliates have been so helpful on this cause in working with me in the last few years, and I'm always forever indebted to the great work of MHA. So let me just go into the basics here. Let's do the parity can become a very, very complicated concept and a very complicated law, but the actual underlying concept behind the law is very simple. Insurance coverage for mental health and substance use disorder treatment should be no more restrictive than coverage for other medical care. That's quite simple, and I don't think in this day and age there are too many people you'll find that would say they don't agree that that should be the case. That's the general concept behind parity. Now, of course, as you're going to see as we get into this, it does get a little bit more complicated as we get into the law itself. Next slide, please. Okay, so very reasonable question that some might ask is, why did we need a federal law to address that very simple concept that we just mentioned? Insurance coverage should be no more restrictive for mental health care and substance use disorder care than other medical care. That seems pretty simple. Why would we even need to legislate that? Well, unfortunately, throughout the history of modern American health care, insurance coverage for mental health and substance use disorder care was much more restrictive than it was for other medical care. And those restrictions came up in the form of very strict limits on inpatient care, like annual day limits, such as 30 days per year or 20 days per year or 40, and often varied by state in terms of what those limits might be. Very strict limits on outpatient care. Annual visit limits, such as 20, you can only see a behavioral health provider for 20 visits in a year. Then another thing that was very common were exorbitant co-pays and co-insurance rates for mental health and substance use disorder care, much, much higher than what you'd see in place for other medical care. Or situations where for medical care there'd be a co-pay of $20 or something like that, but then there'd be a co-insurance rate for mental health care where they would only cover 80%, and that 20% would end up being way, way, way more out of pocket than the $20 copay for medical care. And that was all very, very common. And then another thing that was quite common were separate deductibles for mental health care. So you had your deductible for regular medical care, for other medical care, and once you met that deductible, you still then had to meet another deductible for mental health care before the insurance company would cover the benefits. And oftentimes that deductible would be higher than it would be for other medical care. So those were some of the issues that we had that were very common before we had a federal law. Next slide, please.
Hey, Tim, I'm going to let you take over now.
Oh, okay. I see. There we go. I got it. Okay. Sorry. Okay, so getting back, so also in addition to just the historic behavior of insurers, there were also quite a number of, and as you'll see in the slide, it says state, quote, parity laws were inadequate. And the reason that I have parity in quotations there is these laws were not parity laws. These were generally laws that codified some of the discriminatory limits that were in place. So in other words, the state law said that there only had to be 30 days of inpatient care or 40 days of outpatient visits. And there was even specific language in some of these laws that explicitly said that mental health and substance use care should not be on the same level as other medical care. I mean, there's a number of states that there literally was that kind of language in the state law. And some of these state laws are still on the books. However, thanks to the way the federal law works, they're no longer relevant because the federal law sets the floor. But that was something that was very commonplace. Many states had very restrictive laws in place that codified some of the discriminatory limits that were used by insurers. And then another thing that was very common was that only certain mental health conditions were covered. They had these laws we are called, quote-unquote, biologically based mental illness or serious mental illness laws that would cover, to just include coverage for schizophrenia, bipolar, panic disorder, maybe schizoaffective disorder, sometimes major depressive disorder, and either there would be no coverage requirements for other mental health care or there would be even lesser extent of care for other mental health conditions. And then one of the most common things that I think people will probably find shocking in this day and age, with 72,000 people dying of a drug overdose last year, but substance use disorder treatment was often explicitly excluded from state mental health coverage laws. So that's something that, as we can see, mental health care has been a second-class benefit for insurance companies for most of the history of modern health care. But if mental health care was a second-rate benefit for insurance companies, substance disorder care was even below that. There was often a lot of explicit discrimination permitted within state laws related to substance use disorder insurance coverage. Okay, so because of that historic discrimination and the hodgepodge of state laws, Congress acted back in 2008 the Mental Health Parity and Addiction Equity Act, enacted on October 3rd, 2008, so just over a decade ago. And that, I will refer to that as the Federal Parity Law. It's a bipartisan law. It was sponsored by Kennedy and signed into law by Bush. And the Kennedy was former Congressman Patrick J. Kennedy, who's also my former boss, and then President George W. Bush. And also to underscore the bipartisan nature of it, the law is technically named the Paul Wellstone and Pete Domenici Mental Health Parity and Addiction Equity Act. Paul Wellstone, very, very progressive senator. Pete Domenici, very, very conservative, yet they agreed wholeheartedly on this issue. And I think that's something that, and I'll get a little bit more into that in some of the state work, but there's definitely bipartisan consensus around this. I was just at an event on the Capitol. Senator Cassidy came into the room to talk about the importance of parity. Senator Murphy has talked quite a bit about the importance of parity. So this is something where both political parties do agree that there is a need for parity and this law makes sense. And also this is a needed solution for both the opioid epidemic but also the rising suicide death toll that we're seeing in our country. Now originally, the Federal Parity Law only applied to large group plans. That's 51 employee plans with 51 or more employees, and also Medicaid managed care plans. However, in 2010, the Affordable Care Act extended parity to the individual and small group markets and also applied it to Medicaid alternative benefit plans, which are also sometimes called benchmark equivalent plans. So the Affordable Care Act actually extended parity to an additional 63 million Americans, which had not had coverage previously. So what it does is the ACA amended the Federal Parity Law so it explicitly applies to individual plans. The law itself was changed in 2010 to include individual health plans within the Federal Parity Law. They did not include coverage for small group plans within the law itself, but however, the essential health benefit regulations extended parity to small group plans. So that's how parity applies in the small group market, through the essential health benefit regulations. Now, I know that there's a lot of concern people have had about, well, what does the talk of repeal and replace and some of the efforts that the administration may be taking to potentially undermine the Affordable Care Act, some might say, how does that relate to parity? The good news is that there is no effort, and there has never been any effort within this administration to actually undermine parity through any type of regulatory or administrative actions. And there's none of the repeal and replace bills that were introduced this current Congress, it's coming to an end, would have necessarily rolled back any parity protections. And I think as we've seen from the results of the recent election, I think the repeal and replace conversations are on hold for at least 2 years and possibly forever. But just to make sure everyone's clear on that, there has never been at any time in the last 2 years any serious or any type of attempt to undermine parity itself through any type of actions by the administration. Okay, so let's talk enforcement. So we've got a federal law. Why are we talking about states if it's a federal law? Well, and this gets very complicated, there is a state and federal balance when it comes to enforcement. And I'm not going to go through the ins and outs of all of this right now, but it can be very complicated. But I'll give you an overview of how enforcement works. So state insurance departments are responsible for enforcing the parity law for individual plans and group insurance policies sold to employers. So if you're an employer and you purchase an insurance plan from an insurance company, then the state can regulate that health plan and enforce the parity law on you, and also for individual plans. However, the United States Department of Labor has sole enforcement authority for group plans that, quote-unquote, self-insure. So what that means is, let's say you're an employer, and rather than purchasing a health insurance policy, what you do is you just decide to pay all of your health benefit claims out of your own pocket. That's called self-insuring, and a lot of most large employers do this. And oftentimes, and this can be very confusing to consumers, is these employers will hire a third-party an insurance company to administer the benefits. So even though let's say it's the Comcast group health plan and they're self-insuring, they hire Aetna to administer the benefits. So the person's insurance card still might have an insurance company on it. So that makes it very difficult for consumers to understand whether their plan is a self-insured plan and therefore not regulated by the state, or a health plan that was purchased by the employer. So that's something that can be very tricky to navigate, but and that's a very key distinction. So that's where states cannot do anything about those self-insured plans. Now CMS, that's the Center for Medicare and Medicaid Services, and state Medicaid agencies have dual responsibility for enforcing them when it comes to Medicaid plans. And then there's some other federal agencies, the Center for Consumer Information and Insurance Oversight, known as CIO, and the IRS have some enforcement authority too. However, for CIO, it's very, very narrow, very limited. And IRS, they really don't, it's very complicated as to what role they have in regulating health insurance. But suffice to say, they don't get involved too often. Okay, very reasonable question that I get asked by legislators sometimes. Why are we still talking about this if there was a federal law passed 10 years ago? Well, the very simple answer is insurers and health plans are not fully compliant with the law. There's no unvarnished, that's the unvarnished truth. And that's something that I think off the record some health plans and insurers would acknowledge. State and federal regulators have been somewhat slow to implement the law. This, as everyone is aware, the Affordable Care Act passed in 2010. Because of that, I think that took a lot of the oxygen out of the room for state regulators and federal regulators for enforcing the federal law. Thankfully, that has changed in recent years. I would say the quote-unquote parity IQ of state insurance departments is rising exponentially in the last 18 months or so. There's a lot of willingness by state regulators to get into the weeds on this, and there are a lot of smart people within state regulatory agencies and in the federal regulatory agencies. So I think where this is changing, but that's been part of the problem. In the last 10 years, implementation has only become a priority in the last year or two, except for a few states where they prioritized it sooner. And then, while the concept of parity is very simple, the federal parity law is very complicated, incredibly complicated, maybe the most complicated federal law that exists, and I'm going to show that to you in just a minute. And of course, healthcare is very complicated, and it's something that, while some say, well, isn't there a way to make this law less complicated? I would say possibly, but you got to be careful, because if you make something less complicated with such a complicated topic, you can end up doing collateral damage. So it's a very complicated law, and it's, we're talking about a very complicated animal. That's healthcare. Okay. So on the slides right now, I would not recommend that you read what is on the screen right now. The APA will not be responsible for any retinal damage you might suffer if you do read this. But I will read it for you. So what you have on the screen, it says, this is from the final regulations for the federal law. This is actually the most important, and this is a single sentence in the English language, and the language is English. This is the most important sentence within the federal regulations related to the parity law. A group health plan or health insurance coverage may not impose a non-quantitative treatment limitation with respect to mental health or substance use disorder benefits in any classification less than by the terms of the plan or health insurance coverage as written in an operation, any policy strategy, other standards, other factors used in applying the non-quantitative treatment limitation, mental health or substance use disorder benefits in the classification are comparable to and applied no more stringently than the policy strategy, evidentiary standards, or other factors used in applying the limitation with respect to medical surgical benefits in the classification. So I know what you're thinking now that, Tim, you just lied to us by saying this is complicated. That's really easy. But no, if you understand that by reading it the first time or having it read to you if that's the first time you've ever heard that and you can understand that, I will certainly recommend you for a MacArthur Genius Grant. And if that is not available, I will recommend you for a very stable Genius Grant. So what is that complicated sentence really saying? Because that, as I said, that is the most important sentence within the federal law. So what does it mean? Well, it actually means something pretty simple. Insurers' managed care practices can't be stricter for mental health and substance disorder care than they are for other medical care. And that includes things like prior authorization, step therapy, reimbursement rate setting, establishing and maintaining provider networks, i.e. network adequacy, and many, many, many more. And of course, there's nothing within the law that says insurers can't do these things for mental health care. It just says that the way they do so cannot be more strict than how they do so for other medical care. So if an insurer is doing a prior authorization for, let's say someone just overdosed an opioid and they're in the emergency department and the insurer is doing a prior authorization to see if they can be admitted to an inpatient facility, the way they do that prior authorization can't be any more strict than how, let's say, they would do a prior authorization for someone who just had a heart attack, is in the emergency department and is being transferred to an inpatient hospital facility. So that's really what the nature of the law is all about. It's about the way these managed care practices are performed should be no more strict than how they are for other medical care. And really, when we look at the problems that exist today, this is where we're finding most of the trouble spots, is how insurers are designing and applying these managed care practices. However, unfortunately, and I'm sad to say this, we are still finding some problems with some of the more straightforward aspects. So don't let you think that there aren't necessarily any issues at all with things like co-pays or visit limits. Sadly, in doing some regulatory work myself, I've come across some of these in the last few months. But the major problems are related to managed care practices. Okay, and how do we know there are problems? Well, every time state and federal regulators look into this, when they do investigations of the managed care practices, they find problems across the board that are pretty simple to spot. I don't think I've ever seen the results of investigation into the managed care practices that don't find some sort of problem. And we're not saying, insurers, by no means are we suggesting that insurers are intentionally violating the law. I do not think that's the case one bit. However, I don't know that they're necessarily doing their due diligence to actually ensure compliance. And like we said before, it is complicated, but it is a law as well, and you have to comply with it. And the things that insurers are not doing is they're not internally comparing how they design and apply their managed care practices for mental health substance disorder compared to how they do for medical and surgical. And if they're not doing these internal comparative analyses, there's no way they can say they're actually in compliance. The only way you can be in compliance without doing some sort of internal comparative analysis is through blind luck. So that's something that we really want to see more when it comes to the insurers in terms of their internal comparative analyses that they should be doing. Okay, solutions. So that's something that in the 2017-18, and thanks to a lot of the good work from some of you on the phone, a number of states introduced parity implementation legislation to increase insurer transparency and state regulator accountability. Bills passed, some form of this legislation passed in Colorado, Delaware, Illinois, Minnesota, and Tennessee. There's a bill in the District of Columbia that I think may have passed while we've been on the phone. They were voting on it today. And then, as Barb will talk about, we're very encouraged about the progress for New Jersey. And if it doesn't pass by the end of this year, I think we're very confident it certainly will pass in this session. And the thing to point out that I think is very attractive in the states we've been working in is this has been very, very bipartisan. Almost all of these bills have bipartisan sponsorship, and almost all the bills are passed with either unanimous or very close to unanimous consent. We'll talk about one of the biggest success stories we've had so far is in Tennessee. Tennessee had two separate parity enforcement pieces of legislation, one that passed in 2017 and one that passed in 2018. The one for 2017 was for Medicaid managed care organizations to require transparency on their part, and the one in 2018 was for private insurance to show transparency and also to stipulate how the Department of Commerce and Insurance in Tennessee should enforce the law. And again, like we said before, it requires state regulators to implement parity and also report on their activities, in addition to requiring insurers to report on their managed care practices. So the sponsor in the Senate was very conservative Senator Briggs, and then the sponsor in the Assembly was Representative Clement, who's very, very liberal. And so with the two of them as the lead sponsors on the bill, it didn't take too long for the members of the General Assembly to say, well, if they agree on this, then we might as well bring it for a vote and vote. And they did, passed the Senate 32-0, passed the House 89-0, and signed a law by Governor Haslam. So again, example of how parity can be a bipartisan unifier. And so what we've done at the APA is we adapt. So there was model legislation that a lot of our groups have been working off of for the last few years that I originally created in conjunction with some of the national organizations when I worked for the Kennedy Forum. And what we did this summer at the APA is we adapted this model legislation to all 50 states. So there's a piece of adapted legislation for every state in the country that doesn't already have it enacted. And what that means is, what that adapted to all 50 states means is that it's formatted exactly like a piece of legislation is formatted in that state, uses the correct terminology, amends the right sections of state law, uses the right font type, and all that. So it looks exactly like a piece of legislation. So that's all it needs is the sponsor's name. So our 2019 approach is working with MHA and some of our other national partners like NAMI, National Council, ASAM, American Foundation for Suicide Prevention, Shatterproof, a few others. We're going to be working with our national partners to work with all of you in the regional and state affiliates to determine what states should we prioritize, where is there the political will to get this done, and then and then introduce legislation and try to get over the finish line. And what we're really trying to work on is the messaging. We want to make sure that this is framed as parity implementation is an important tool for solving the opioid crisis and rising suicide rates. And also, what was always really, really helpful, and I think what I've seen working with Barb in New Jersey, is having families who can share stories about how not having access to adequate insurance coverage has really harmed them and their loved ones when it comes to getting adequate mental health care and substance use disorder care. That can be really persuasive for legislators. You can have someone like me come in and talk to a bunch of legislators. They don't really care what I'm saying. What they really care is what families are saying, what consumers are saying, and what voters are saying. That's what they really care about. Okay, so that's my portion. I'll pass it over to Barb.
Well, before Barb jumps in, this is Debbie Plank, Mental Health America. I'm Vice President for Mental Health and Systems Advocacy. And for those who have joined us after we got started, welcome. We're glad to have you. Again, I want to thank Tim Clement from the American Psychiatric Association, who is without a doubt the nation's expert on parity legislation, model legislation. And you saw on Tim's slides the links for the states and the model legislation. All of these slides will be available to you in about a week or so. We'll send you an email telling you it's available. You'll be able to hear the recording. You'll be able to download the slides. You'll be able to click on your state and take a look at that. So again, we thank Tim. And if we ever fish our wish and we don't have to work on parity within the next couple of years, Tim can always get a job doing those voiceovers and commercials when there's special this at the bottom that go really fast, because you did that marvelously. So that said, it is my great pleasure to introduce another of our regional policy representatives, Barb Johnston. And Barb is the Director of Policy and Advocacy for the Mental Health Association in New Jersey, again, one of our Mental Health America outstanding affiliates. And Barb has worked in healthcare for more than 25 years in many diverse positions. She began her career in mental health, working with programs for deinstitutionalizations, working on addiction, inpatient and ER crisis areas. She had worked for a pharmaceutical company, and she started their employee assistance plan and their managed career centers. Over the next 2 decades, she managed projects through the research and development process, worked in public policy, state and federal government affairs. She's worked on reimbursement, payer markets. She's worked on mental health issues in prisons, managed care, long-term care, market specialty, all kinds of products. Barb is really quite the expert on insurance products and, again, in parity. Barb chairs the New Jersey Mental Health Coalition, and she serves on the Board of Trustees for the Community Health Law Project, collaborative support programs in New Jersey. Along with the government affairs teams at MHA of New Jersey, she's responsible for legislative activities, policy, and advocacy. It's our great pleasure to work with Barb, who's going to tell us about some of the outstanding work that has happened in New Jersey. Barb?
Thanks, Debbie. I'm trying to figure out how to advance these slides, Karen.
Hi, can you press the forward arrow button on your keyboard?
I don't have a forward arrow button, so why don't you do it?
Okay, sure. There we go.
Thanks. Thank you. Now I see it. Thanks. So I'm going to talk about New Jersey. And we have a bill right now that is a transparency bill, that it's weaving its way through the legislature. And we're very excited about this bill because it creates so many opportunities for us. What it does is it enhances the enforcement of behavioral health parity laws, which exist. We have both state and federal laws. And as Tim said and so eloquently explained to everyone, we really have a focus on the non-quantitative treatment limits, the NQTL requirements that are in the federal law. And this bill really holds our own Department of Banking and Insurance, we refer to them as DOBI, to be accountable for really making sure that the plans collect the data that they need to, analyze that data, do the follow-ups necessary with those plans and payers regarding their compliance, and then, very importantly, taking this data and putting it in an aggregated form and making it available to the public. We say aggregated because we wanted to take the competitive nature out of what they were doing. And we wanted to make sure they weren't using it as a marketing advantage or disadvantage. What we really wanted to show was how is New Jersey doing in terms of parity? Are the members of these payer plans getting what they're paying for in terms of behavioral health parity? Next slide. Well, what happened here? Karen?
Are you advancing the slides, Barb?
I I was, but it's, can you bring me back here, Karen?
Okay, I'll take over control now.
Thank you. So what we found is our law has gone through, so far, the Assembly, and it went through committee, and of course, almost unanimously, as Tim said, these things just are remarkable in terms of the levels of support that we're having for them. If you look at it in your own states, really, there's a lot of surrounding opportunity around getting involved with implementing parity legislation. It's a huge opportunity to educate legislators not only on mental health and substance use, but also on co-occurring conditions. And we know for a fact that there are many individuals who have substance use conditions who also have co-occurring mental health conditions, and also have mental health conditions have co-occurring substance use conditions. We have a helpline, and we find that we're running close to 50% on almost both sides with individuals who have both conditions. And this is an opportunity to really talk to the importance of integration of both behavioral health care, meaning mental health and substance use, and co-occurring conditions, along with physical health care. And I know many of you on this line have that as your priorities, and the discussion around parity legislation really helps you bring home the point about the importance of integration and care and making sure that these laws are no more restrictive for behavioral health than they are for physical health care. So we find that it also allows us a great opportunity to work with many colleagues across all segments of the market: public, private, providers, peers, mental health, payers. And by doing that, we really are able to share our priorities, help each other understand what our priorities are, and come to very good consensus on what's important to drive this forward. And of course, the opportunity, it really creates a lot of media awareness and public awareness around access issues for behavioral health services. Very important. Next slide. So just a couple of key points I'd like to review about what we did in New Jersey that we think made us so successful and really able to create so much awareness around this. So I would recommend that if you have a parity coalition in your state, you should join it and become a very active leader within that coalition. If you don't have one, I recommend you start one. Ours involves everybody. We allow anybody to come to the table and encourage a broad list of people and organizations participating. So we have, as I said, we have peers, we have providers, we have family members, we have legislators, we have pharma companies, we have organizations, advocacy, physical health care, everybody. It really is a very, very large group. We meet once a month and are able to really keep the energy going around people just getting involved, understanding where we are in the legislative process and what's needed. Also, what we did, I think, which was very important for us, and Tim talked to this, is to make sure that we have influential bill sponsors on both sides of the aisle. And we do have that in New Jersey. We have leadership for both Assembly and Senate, one Republican, one Democrat, and they're extremely invested. For our Assembly bill, I think we had more than 50 co-sponsors, all parties. And in talking with the legislators, it's very interesting because they have people coming into their district offices to complain about access issues, to complain about denials, and they feel very helpless. We get calls from them, and they really see signing on to these parity bills and supporting them in a very proactive way as helping their constituents very directly to obtain the kinds of services they need in the long run. And also, we recommend working with the payers. And if there is resistance to the parity legislation, it is from the plans. And although they tell us frequently they're not resisting to the legislation, they just don't want to add more bureaucracy. But we do find that there is some dragging of the feet. But we feel very positive that we've worked with payers from the very beginning. We made a lot of amendments in the bill along the way. But we were able to retain the important guts of the bill and what was really needed to make it meaningful. And I credit, again, Tim on this, who did a miraculous job in really working very, very closely with the national organizations and getting them to really understand the value of this and how it would not add more bureaucracy to what they do, but instead really is just complying with federal guidelines and standards and laws. So Tim did an amazing job, and we think we do have good support from them at this time. Next slide. So we also did a very thorough job of meeting with everyone that's potentially involved with this in the administration, within our government. We went to the Department of Banking and Insurance, went over the bill with them, make sure that they understood it, governor's policy people, all of as many levels as we could within the mental health and substance use departments so that they're informed. We met with all of the committee chairs and the members on the committee before it went to testimony to make sure that they understood what was in the bill. Again, Tim said this is a nonpartisan issue. We get support across the aisle. People look for opportunities to really support the bill, the legislators. We also had a lot of opportunities with media to be on panels, to really present and educate. Because as the bills are heard, media is paying a lot of attention to them. And it really created a lot more interest and a better understanding of access to behavioral health care and some of the challenges in our state. But again, the biggest impact are the stories that people told at testimony, the stories that we've reiterated in our newsletters, and this is really what makes a difference. Sharing personal stories, that are facts to legislators from constituents, making sure that people understand that it's a personal issue. And we've had some amazing responses to our hearings and to the mailings that we've done, and from legislators responding individually to a very strong grassroots network that we have, that we can really have people within their own districts telling them why it's so important to support this legislation. So, I just leave you with that stories do make the biggest impact. Thank you.
Thank you so much, Barb. We appreciate hearing about the wonderful work in New Jersey. Again, this is Debbie Plotnick. If you've just joined us, we're so happy to have you here as we talk about parity and lessons from different states. We've heard from Tim Clement, our absolute national expert and expert in all things state legislation. We've heard from Barb Johnston, who is our regional policy representative from MHA of New Jersey. And we're going to hear now from Rebecca Swanson from our MHA affiliate in Colorado, from Mental Health Colorado. And Rebecca joined Mental Health Colorado in 2017, and she comes to MHAC with 15 years of public policy and research experience. And before she came to Mental Health Colorado, she was the research director for the University of Denver's Strategic Issues Program. She's been a senior policy advisor to Governor Bill Ritter, and she's looked at local affairs and the intersection between state and federal policies. She represented the governor and the Western Governors Association staff. She's really been very involved with governors, and she is very familiar with how state government works. next, Rebecca also has a master's degree in public policy from the University of Denver, and even as a student, she was a research assistant for Governor Richard Lamb. She's really quite the expert in mental health. She studied neuroscience at Colorado College. She has lots of experience in education as well, and she came to Colorado from Minnesota. And as she and I earlier today talked about, the view in Colorado of the mountains is very different than in Minnesota, and we're delighted to have her as part of our network now. And Rebecca lives in Denver with her husband and her two fabulous children, and she has a toothless dog. But she's going to tell us about the terrific advocacy with respect to parity that have been learned in the short term from Colorado and some of the places they go from here. Thank you, Rebecca. Please go on.
Thanks, Debbie, and thanks to all of you who've stuck it out. I know parity isn't an easy topic, and you've had a lot of information already today. I will try to keep it brief. First, I wanted to say that I'm standing here next to Senator Mo Keller, who worked for Mental Health Colorado and also spent 16 years in our state legislature and was our pioneer of Colorado's parity laws. She did incredible work. And when I started here in 2017, we had a series of community conversations around the state where we went and talked to different communities and said, what are the obstacles you're facing? And we heard time and time again stories from people who, despite our excellent state parity laws and the hard work of folks on federal parity laws, we heard about people getting their claims denied, their coverage denied, or sitting on wait lists for months sometimes at a time. And so we then launched a very non-scientific parity survey, and we've had hundreds of respondents so far to try to get a little more in-depth on where the issues were. And it goes back to Tim's conversation around the non-quantitative treatment limitations when we're hearing regularly about network issues and people with wait times and people who have to jump through extra hoops and have more prior authorization hurdles to jump through and all sorts of those issues that most of you are very familiar with. We also last November watched closely the results of the Milliman study, which showed that Coloradans with private insurance go out of network for behavioral health care 7 times more than for physical health care, and behavioral health providers are reimbursed some 40% less here in the state of Colorado. These are all a really big concern to us, and so we really thought, what can we do to start to make a dent in this enforcement business that Tim's talking about. So we went to a lot of meetings. We worked with a lot of partners.
I think it sounds a little complicated.
Can you throw me on the next slide, Karen?
Sure.
Thanks. And we, together with Tim's great work, he was then at Parity Track and now, of course, with the Psychiatric Association, we formulated Colorado House Bill 181357. And this bill does 3 things. The first thing it does is create a state ombuds office. The reason we really focused on this was because with our research that we were doing, with all the anecdotes we were hearing, we ran into 2 big problems. One is that all the folks that were writing into us and telling us their issues, they all had different carriers. They all had, some were regulated federally, some were regulated by the state, some were private insurance, some were Medicaid insurance, some came in with no insurance at all. And we thought we really need one place where people can go with all of these complaints. And the other piece of it is when we were going and talking to state regulators who are close partners of ours and we spent a lot of time working with, they said one of their issues is that they don't receive the complaints oftentimes in their office. By the time people have to go through the process of appealing with their carrier or going through a lot of hoops in that process, they often don't make it to the Division of Insurance in the first place or to the Medicaid office. And so we created this ombuds office where people who are privately insured, publicly insured, not insured at all, can call with questions and complaints about Specifically, we're focused on parity, coverage, and network issues. Our hope is that this is a one-stop shop. We had bipartisan support for this bill. We had a lot of partners, which I've outlined on the previous page, many of whom are on the phone today. I know the Colorado Psychiatric Society, Hospital Association, Colorado Coalition for Parity, who's been working on this issue for a long time here in Colorado, NAMI Colorado, Colorado Behavioral Health Council, and of course Tim, who spoke earlier. There are two other components of this bill that were really important to us. One is a requirement that this new Ombuds office will track the complaints and the calls that are coming in, and besides following these calls to resolution and helping folks get to the right place to file formal complaints or just navigate the issues they're having, the Ombuds Office has to track these complaints and report annually to the governor, the legislature, and the public. And we're hoping with that component we can really start to clearly define where the issues are. Which NQTLs are we struggling with the most here in Colorado? Which places are, which carriers are we seeing the most problems with in terms of, is this more in the private sector, is this in the public sector, is this in both? And then we had a third piece that is pulled out of the Ombuds Office that requires the state's Division of Insurance to report on any methodology and corrective actions they're using for parity compliance. Specifically, our Division of Insurance has been working on a market conduct survey over the last year, and we want to make sure the results of that are made public. So it was a great effort. There were a lot of folks at the table. Barb addressed sort of the advocacy ways of making sure you have bipartisan support, making sure you have a lot of folks that you're talking to. We did all of those things, and really educating the community, bringing in people who've had experience with these issues to testify, all of those. It was still we had a lot of work getting this bill through, but at the end of the day, it came out with strong bipartisan support. So that was signed into law in May, and now we have some next steps we're working on. We just worked on interviewing and selecting an ombudsperson. Kate Harris was appointed to serve in this role by our governor on November 1st. She's going to begin her work in December. And here's where it's really important as an advocacy organization to not just work to pass the bill and then hope it works. We are going to be right there. We're making the offer to her to set up meetings to tell her what we had in mind in the bill, to bring stakeholders and supporters to the table to help guide and shape this office as much as we can. Including some exciting news. Recently, we talked to the Federal Department of Labor and told them about our work here, and they're really interested in having a direct path from the Colorado Ombuds Office to our Regional Department of Labor to take in complaints from Colorado and help us track the data coming back from those complaints. So that's a really exciting piece of news for us as well. And then, of course, we're working with the state's Division of Insurance to follow up on the transparency piece and making sure that what needs to become public and what we can follow up on does become public. So that brings us to our next part. Tim talked a lot about this model parity legislation that he's been working on for all 50 states. And it was a great first step last year that we did this Ombuds bill and the DOI transparency component, but we think there's a lot more work to be done. So early on, Tim and I talked about this model legislation and how we could take the basic elements of this and also take the information we have from the research we've done with our partners out in the field, our surveys, and add elements that we think are extra important to Colorado, and maybe to everyone, but really unique to where we are. So this is what we're working on right now. We just elected a new legislature and a new governor, of course, exactly a week ago. And so right now we're finalizing bill sponsors. But what this bill will look like is the model legislation at its core, and then adding bits and pieces of Colorado-specific components. So, for example, we're going to take some parity language that is now outdated, that was great when it was first passed, but refers to things like biologically based mental illness and lists out, itemizes specific disorders while leaving others out. We're going to update that. And we'd also like to set the stage for a new world of everyone's talking about, how can we get to this point where brain health is seen as brain health, is seen as health is health is health. How can we make sure that as we're modernizing our parity language that we are moving towards that future while still maintaining all the benefits that we see under parity? We're going to work on increasing transparency and reporting requirements for both private insurers and for Medicaid, similar to what Barb is doing in New Jersey. We're going to clarify and strengthen requirements around these non-quantitative treatment limitations. One example we're really focused on here, in part because of the Milliman study I spoke about earlier, is network adequacy and access requirements. And here's where I will talk for a bit about, we go out on the trail and we talk about our state requirements that everyone who needs to get in for a mental health visit, for a non-urgent visit, is supposed to be seen within 7 days under our state regulations. And when we go talk about that in a room full of people who are seeking treatment or in a room full of providers, we get laughed out of the room. We know that this is not happening. We know that sometimes it happens, but we hear many, many stories of people who are unable to find this care in the time they need. So we're going to work to address that in the bill. At the same time, we hear from providers who say they want to get on networks and they're getting denied from networks. And so these are things we're really focused specifically on here in Colorado. We're going to work on clarifying and strengthening some preventative care requirements. We think that just as parity applies to all of treatment, so too should it apply to preventative care. And as part of this as well, we're going to make sure that consumers know their rights in any way we can. For example, I think it was maybe the state of Illinois, one of the states worked to acknowledge parity laws right in their insurers' explanations of benefits and adverse determination notices. We're going to look at ways that we can get the word out to consumers where they're actually seeing these papers. So I guess that's really all I have right now. It's been really exciting to work with you all and have the support of Mental Health America, of course, and you, Tim, thank you so much, and I will turn it back to our folks over at headquarters.
Thank you, Rebecca. That was extraordinarily informative, and as folks on the webinar can hear, there are many things to look at. There are always pieces to the parity puzzle, the network adequacy, whether or not people are having the obvious things that Tim talked about, how important it is to have coalition, and how helpful it can be to make parity a priority when people are buying insurance and looking at their insurance plans, because that's the way that we'll get to helping folks with mental health and substance use conditions before stage 4. So again, we really want to thank our presenter, Tim Clement, from the American Psychiatric Association, Barb Johnston, from the Mental Health Association in New Jersey. We would like to thank Rebecca Swanson for joining us from Mental Health Colorado, and for all of you who have joined us today on the webinar. Again, the slides will be posted in about a week. You'll also be able to hear a recording of the webinar, and you'll be able to interactively click on the slides and get to the 50 states there. So we, again, really appreciate joining us. We have, Karen, is there another slide with the contact information for our presenters, which I think there is, and if not, we'll get that up there and add it.
Yeah.
If you have any specific questions about Mental Health America, please feel free to contact me. I'm Debbie Plotnick, Vice President for Mental Health and Systems Advocacy at our national office, and I'm D. Plotnick, DPLOTNICK, at mentalhealthamerica.net. And again, thank you all so much for joining us. Bye-bye.